On to our next speaker, Dr. Josh Umbehr. He is a family practitioner in Wichita, Kansas, and founder of AtlasMD, a direct patient care practice based on a monthly membership. Josh's practice has grown to 4 physicians, and he speaks on his model across the country. AtlasMD is a turnkey model, including a physician-designed and patient care-centered cloud-based EHR, available to physicians for a simple monthly fee with no setup costs. Josh has helped physicians across this country set up direct care practices, including 80 in the past year, and my own practice being one of them. Welcome, Dr. Umbehr, and thank you for joining us.
Good morning. Thank you for joining the conference. We appreciate your commitment to learn more about how doctors can practice independently. My name is Josh Umbehr. I'm a family physician from Wichita, Kansas, and my specialty is direct primary care. We started our practice, AtlasMD, Concierge Medicine, almost 5 years ago this September, with the idea that insurance is simply complicating more things than it helps. Not that insurance is bad necessarily. I think it's a tool, and we're just using it incorrectly. But the idea was that insurance was creating more barriers than solutions because we were insuring things we shouldn't be. And you wouldn't have car insurance that covers gasoline, oil changes, tires, because those are already affordable things. So why would we use health insurance to cover medications and labs and office visits if we can make those affordable? So when we started, fresh out of residency, with 0 patients, 1 doctor, and a dream to not go bankrupt, so far so good. We now just added our 4th doctor and are looking at a 2nd location. But more importantly, the movement has grown, and we've helped do consulting with over 80 physicians in their practices in the last 18 months or so to launch very similar models. And there's lots of other doctors helping each other move into direct care. But a lot of doctors have questions about how it works and what the future holds. But to start with a summary of our model, it's a membership model because we felt that answered more of the billing questions. You can't bill on diagnosis code because patients don't know what that is. Or complexity, they don't know if they're complex or not. And they're very price sensitive. So we wanted to make sure that there was a connection between how much they paid and how much time they felt they were able to get. So the membership answered most of those issues for us. We charge $10 per month for kids, and then $50 is our average price for most adults when you factor in our employer discount. And then for that membership fee, they get unlimited home visits, work visits, office visits, and technology visits, email, cell phone, texting, Twitter, Facebook, Skype. Because we have less HIPAA restrictions and our patients sign waivers to allow us to be more flexible, we can meet them at their most comfortable spot online. Furthermore, we eliminate copays because copays are meant to get people to have less care, and induce a little bit of skin in the game for the insurance company. But we want our patients to access as much care as possible. So we've eliminated that aspect. Furthermore, any procedure that we can do in the office is free of charge. Stitches, biopsies, joint injections, ultrasounds, DEXAs, ultras, spirometry, rapid strep, urinalysis, cryotherapy, lesion removal, minor surgical procedures like toenail removal or lipoma removal, all because those represent a very affordable cost to us that we can absorb so that we can do an EKG for 36 cents. I want my patients to have the EKG because it costs us so little. Even if we were making a profit off it, it wouldn't really be enough at that price point to worry about either way. But also it's another value add to the patients. You don't have to think about it again. I know if I'm using Netflix and there's a popular series, I don't have to pay more for the pieces that I really want to use. Then one of the pieces that I think has made us incredibly successful is the wholesale medications, labs, radiology, pathology. Being able to add all those value points to this model really allows us an opportunity to save our patients in a way that's unprecedented. I get 1,000 LASIKs for $8.33. So we mark everything up 10%. We're very transparent about that. Costco marks everything up 14%. The CEO of Costco is also on record as saying every good idea they've stolen. In the sport of business, you're competing against each other, so we can say we took that idea from them. But it's transparent, and patients like that trust. I can tell every patient, doctor, employer, insurance company how our pricing structure works to be very clear and add a level of trust. But I can get Imitrex. It's normally $100 to $200 at the pharmacy for $6 or $7. Other medicines, omeprazole, I get 1,000 pills for just under $50 now. And there's countless examples. We even have been able to help a patient get chemotherapy for, I think, 98 or 99% cheaper in that case. So labs, I can get a CBC for $2, an A1C for $2.71. After my markup, PSA is less than $3, TSH is $3 or $4. So now I just had a doctor visit the office from Maryland, and his wife is the family physician, and she asked, well, what would these couple of tests be? TSH, a SED rate, a lipid panel, et cetera. And she said, well, I know the SED rate's expensive. It's not. It's $4 for us. They were blown away by the fact that we could do $20 of labs and do everything we wanted, and that was $700 or $800 billed through their hospital-owned practice. So it's doctors coming back at this and saying, how do we do this better so that it benefits our patients in a meaningful way? I think business and medicine have long had a love-hate relationship, and doctors have been afraid to embrace the business side because our profession says you can't be a caring physician and a successful businessman, that somehow there's a contradiction there. And I don't see that contradiction. I think if we take our oath seriously, we have to say do no harm means do no financial harm. That instead of complaining to the system of insurance and the government and say, well, make these things cheaper, we can do that. We can take on that responsibility ourselves. And when we do, it's amazing when it gets cheaper. Pathology used to be $300 a sample. Now, by going out of state to Boise, Idaho, I can get it for $40. I should get it for $40. I should be constantly asking what can I do to help my patients save money, because saving them money means they're healthier, or gives them the opportunity at least to be healthier. But if I'm worried about a melanoma, then they're going to have stress about it at $300, but at $40, it's a tank of gas. They can absorb that. There's no financial debt that's going to be accustomed to or connected with that procedure. So then the real beauty is we can take all of these value adds, and I can't say that enough, add value, but we can go into an employer's insurance company, decrease their premiums by 30 to 60% year one. And our success in that is that even the insurance companies are saying when they get a few more years of data on it, they predict they'll be able to push the costs even lower. So where everyone else is seeing a very dim, dark future in healthcare, we see bright opportunity coming on board because we are, I think, putting the patient first, using sound business principles, adding value, but removing red tape. One of my favorite quotes is from George Bernard Shaw that says, there's nothing so useless as doing efficiently the work you shouldn't be doing in the first place. But why code strep throat and depression and anxiety and weight loss and all these things to get paid when we can just get paid from our patients? And that actually saves them money. So now our employers are decreasing the premiums so much employees get a raise. Cheaper meds, unlimited visits, no copays, free procedures, wholesale meds, labs, like radiology, pathology, and cheaper insurance premiums. We often joke that if you get it, you should wave the BS flag. It should feel too good to be true. And I think for a lot of patients and employers and doctors, it does feel that way. And so, but the more time we spend, sorry about that, the more time we spend with our patients, the more we can save them money. And it's just a paradigm shift. It goes from billing for every little thing to having a flat price. And it's nice because if you're really poor, you can text message your doctor and never leave work. If you're not leaving work, you're not the low-producing employee. Or if you need a migraine shot because It's that or go to the ER. Well, I get Toradol and promethazine for under $2 a shot. So I can prevent a low SES individual from going to the ER, getting into financial trouble, all for migraine treatment that their family doctor, can offer to them at a fraction of the price. So it really is a sound business principle of aligning the incentives. So the patient comes first. The doctor is responsible for a lot of diagnostic testing. We can decrease the cost of that. Then they can pay through their HSA or deductible. Then the employer is fourth or fifth to pay. So that protects the insurance interest because we're managing their risk better. If we do that, they lower their premiums. If they lower their premiums, then more of my patients have insurance. So at this point, you're probably asking, well, how does that work in a post-Affordable Care Act era? Well, it still works pretty well. So most of your patients are going to fall into one of two categories. They're either getting their insurance in the exchanges, and you can't necessarily help them lower their premium costs, but you are helping significantly on their out-of-pocket costs. Because now they're essentially underinsured. And most of what they need, unless it's considered preventative, won't be covered. So you're still helping them with the high cost of meds and labs and co-pays and procedures. But for employers, we're going to move into a self-funded or ERISA plan, an ERISA. Those plans go back to a 1974 law that exempts them from state and federal mandates. So you have a lot more flexibility on designing those plans. And the way they're structured is any money not spent at the end of the year goes back to the employer and the employees. So they have some nice financial incentive to say, let's be healthy. Let's utilize the direct care doctor for cheaper meds and labs and co-pays so that there's more money left in that pot at the end of the year. So some of our employees are getting a $1,000 bonus because they effectively use their health care well. Not because they ration the care in the traditional system. They may get unlimited access through us, but they did it in a way that was much more cost effective. So that's one of our key strategies. And I think moving forward, the future of this is going to go from niche to mainstream as more doctors see that this is a viable option for them and their patients. The old days of this being concierge medicine, for the 1% elitist, those days are gone. This is direct primary care that's affordable to the masses. And the idea that insurance or government is going to stomp this out is gone, because we are trying to build synergy with all those groups to say 2 + 2 = 6, that whatever we're doing is building value for all parties involved. And we avoid the meaningful use regulation and the new Medicare value-based billing, which is still going to be very complex for most doctors, and ICD-10, which I think will really be a stress to most small practices. We can step out and avoid a lot of those troubles and have more time to focus on our patients. So let me tell you about an average day in the life of a direct care doctor. We have 600 patients instead of the average 2,000 or 3,000. We see on average 1% of our patients per day. So if you had 800, you might see 8, which is still wonderful because that's minimum of 30-minute appointments, so plenty of time with them. Answer probably a similar number of patients by phone call, text message, or email throughout the day. But if a patient needs an hour, I give them an hour. The appointment's over when their questions are over, not when I have to be, when I'm already 5 minutes late to the next room. And that ability to only see a few patients a day, we kind of have to. Family medicine is messy. Anything can and does walk in. And you have to be ready for that so you can help the patient when they need it. But we're counting pills, we're drawing blood, we're answering phone calls, but it's an enjoyable, relaxing day with our patients as opposed to the grind of 20, 30, 40 patients. We have 1 staff member for every 2 doctors, which seems really low to most people, but we're not doing all that unnecessary work either. So we don't need extra staff, and that means lower prices to the employees or the customers, and then more revenue for the doctor. The average doctor in this model is going to aim for $50 in revenue per person per month, times 600 patients. That's $30,000 a month, or $360,000 a year, and an overhead of about 30%, which is mostly staff and lease And so that gets a family doctor seeing 6 patients a day, somewhere in the range of $200,000 to $240,000 in income, which I think is more than fair. We can see more patients and add to that, or we can add more patients and lower the monthly membership. But you know that the money you're making is because you're saving patients time and time again. So it's a way that you can really feel good about practicing. In fact, the plant over my shoulder is from a physician who came out of retirement recently, earlier this year, and said this for the first time in his professional career, felt like he was practicing family medicine for the right reasons in the right way because of direct care. And I think that's what we're all going for. Stop the burnout, stop the frustration, get back to a logical, reasonable system that helps our patients and adds value. So from there, I think we'll take questions from the audience. But thank you very much for your time and for allowing me to share our story with you.
Well, hello, Dr. Umbehr. Mike Strickland.
Hi. Hey.
Hi, Josh. It's great to see you and great to hear from you. Thank you so much for joining us and speaking. I want to take just a moment to introduce two of our guests here that have come up from the audience. Dr. Lisa Chu, who is an MD, who, for I believe some of the same reasons that we are here today, decided not to practice medicine. And she has had an interesting career since getting her MD. And then Dr. Cedric Simpson, who is an internist and ER physician. And welcome to our panel. And
Thanks, Mike.
we're going to go ahead and have some questions for Dr. Josh. I want to let the audience know that I met Josh last fall at a conference. Really liked what he had to say. Then I went to Wichita and saw his practice in action, and really liked that and adopted it. So I'm using that in my own internal medicine, primary care, since January, and I really like the model. One thing I really most like about it is it frees me up from all those distractions that we've been talking about this week to focus on my patients. The patients love that. I love that. I don't have those huge costs incurred of the systems and personnel needed to do those type of third-party billing and coding. And I just think it's working out really well. You know, it also rewards the doctor for taking good care of the patient. If you do a good job, you're going to have less work to do next week on them. So one question I have, though, Josh, in my own experience, the missing piece of my puzzle is finding an affordable major medical policy to cover those catastrophic events. And I know I've heard you say that you've been able to negotiate for your own patients 30 to 60% decreases in their premium because you're able to demonstrate fewer ER visits, less usage of the insurance. So can you elaborate on that?
Yeah. I think one of the reasons we've been successful is that we were early on fortunate to connect with some insurance experts, Dave Powell and Joe Martin locally. And what they said was that the value of the membership model is great, but can they combine that with an insurance policy by carving out the unnecessary parts? And, that was Joe's question to Dave, that Dave, being a 40-year insurance veteran, was able to, as general manager, have more privileges with most of the insurance companies so that he could do carve-outs. Everybody but the Blue Cross in our state offers a self-funded plan or more flexible option pre-Affordable Care Act. So that gives us a lot of leverage in lowering the premium and adding back membership. Post-Affordable Care Act, it really seems that our main focus is working with insurers who can offer a self-funded policy, technically called a partially self-funded policy or an ERISA, E-R-I-S-A. And that actually goes back to a 1974 law that exempts them from state and federal mandates. So with those kind of policies, either through our specialists or through local specialists, you can do the pharmacy carve-out, the lab carve-out, the co-pays, the insurance for urgent care, emergency care. Lord knows most of that can be done in the direct care office. So when you're not filing claims on the insurance, then there's no increase in premiums, but also insurance isn't responsible for the stuff they shouldn't be responsible for. So even the insurance company is supportive of this model because what they say the administrative cost alone is enough to justify the change, but also the patients are getting more care more often, but the insurance isn't in the business of insuring LASIK that costs, 1,000 pills is $8.33. So we're getting back, helping them get back to a more reasonable policy, and for that, better premiums, happier employers, happy patients.
So are you negotiating through to the insurance companies themselves, or should a doctor that wants to adopt your type of model find some local insurance brokers that can mediate that? How does that work exactly?
Yeah, definitely I will look through the insurance brokers. One, they have time, two, they're licensed for it, and three, they're the ones who get to get for it. So a lot of the insurance guys are also financial advisors, and they may not have as much value in the insurance of 2 or 3%, but a lot of value in the spin business of AFLAC and 401k and retirement plans, etc., which a lot of employers haven't been able to do lately because the cost of insurance has skyrocketed so much. It's sucking money away from other employee benefits. So there's a lot of value in that for a financial expert. Some aren't as comfortable or familiar with that model, so they might need to contact our guys for some training and help with understanding that. But whether it's through our help or your own local help, that is one of the key ways to grow a direct care practice and help employers.
Okay, thank you. I have one quick question and then I'll turn it over to the panel. But is there any data showing the outcomes for direct patient care?
Yes and no, interestingly. Groups like Humliance do a very good job because they have so much money of tracking their patients across the system in showing decreased ER visits and especially referrals. But then in some ways, it's the evidence you never see, the dog that doesn't bark. I think the ultimate number for the insurance company is price per member per month. And we've had groups of employees go, groups of 15 to 50 go a full 12-month cycle on their insurance policy and file 0 claims. So even the insurance company is pretty shocked at that. And that's the evidence that direct care does better. Sure, we can show better A1Cs and more compliant patients because of pulse meds, more testing because of pulse labs, etc. But the real point that matters is the fact that we're not filing, that we're not raising the cost of healthcare to the system drastically. So it's all that money saved because we're providing care in-house, and sometimes that's a little harder to track. But.
Okay, thank you. Well, I'm going to turn it over to the panel. Do you have any questions?
I do. Josh, Dan Cravioto here. I'm an orthopedic surgeon in Santa Barbara, California. Thanks for coming on with us, first of all. But do you think your model would work for a specialist, say an orthopedic surgeon like myself?
Absolutely. I think we get that question a lot about how this would work for specialists. And what I see is a continuum of chronic care. And so on one side is fee-for-service, dental care, pathology, radiology, surgery, kind of like the Surgery Center of Oklahoma, where a lot of that is here to say fair price for a fair service, but knowing that it's maybe one time or limited. Then after that, moving across the spectrum, like you see some specialists like orthopedics or dermatology who do have patients with a chronic care component and that would benefit from an appropriately priced membership to have that sort of access. But for orthopedics, I can see how they would be on the far end of the chronic care spectrum for sports medicine and those high-performance athletes who are going to need more monitoring and maintenance and follow-through. So then something like cardiology would fit nicely in the middle because it has an acute care and chronic care component that doesn't compete against each other. But then we've helped endocrinologists in various states like Boise, Idaho, do a direct care model because essentially it is a chronic care type of medicine, whether that's internal medicine or pediatrics or women's health or family medicine. I think that's closer to 95% membership with maybe some incidental fee-for-service type stuff. So I think just depending on the specialty and the type of medicine you're providing, you can quickly dictate where you fall on that spectrum and map out your insurance-free model accordingly.
Thank you.
Panel, any other questions?
I do have a question. In your region, are there other direct-to-practice physicians?
Yes, we have a number of in the area. Some that we've helped start. We do offer home consultation for free. We have a Spartan packet that doctors can access for free. We don't need to. A key part of that is everyone is doing it well and successful and using the best information. 90%.
We're having trouble hearing you, Josh. Excuse me just a minute.
So yes, we do have a number of direct care practices in the area. And again, many that we helped launch because we want to see them all be as successful as possible. I don't see it as competition because there's enough patients to go around for everybody. So we do offer all the consultation for free because we want to see every doctor doing this to be successful. But also we know that every doctor who does it and fails creates a disproportionately large splash. Everyone is more risk adverse. So they need to see 10 succeed for every one they see fail before they feel comfortable enough doing it themselves. So for those reasons, we help as many doctors as we can. But we have several in the city and several in the city surrounding us.
I'm wondering if you share ancillary services.
We don't right now. We sure could. If somebody had, I mean, in some ways we do. There's another doctor in town who wanted to do a bunch of our DEXAs for his patients that screen for osteoporosis, and we have a DEXA. He also wanted to use that for a weight loss plan competition that they were doing. And I'm sorry there's some feedback there, but and so we let him come into our office and use our equipment for that. So there, I think most physicians are happy to work together enough to share those sort of services and help each other out because we're helping out our patients.
Let me see what our chat says.
Okay. Dr. Dorio asks, does your model allow for senior patients to be cared for through Medicare, or have they been eliminated from your practice? If the latter, what proposed model do you have for them?
Yes, we can take care of Medicare patients. You know, the easiest way to do that is just to opt out so that you don't have any conflict with CMS about this. But this model works out beautifully for them for the same reasons it helps everyone else, which is you're helping save money, you're improving access and quality and time with the doctor. And I know in our town, like many towns, it's next to impossible to find a physician taking new Medicare patients. So for a senior citizen to be able to choose their doctor, someone they like and who spends time with them and practices the kind of medicine that that patient is looking for, not to mention helps with saving money on meds or labs or services or consultations, etc. So I think in a lot of ways this serves the Medicare population the best. They need the most health care and we save them the most so that we make that more affordable.
So we have a chat question from you, from Dr. Claire Coco. She's a primary care physician in New Braunfels. She asks, do you offer same-day patients, and I think that means offer same-day appointments, then on-demand and weekend hours?
Yep, we offer, I'd say 95% of our visits are same day, and the rest are just because the patient wants to schedule them out farther. You know, the fact that we have 600 patients per doctor instead of the normal 2,000 or 3,000 means that we only need to see 5 or 6 patients a day in the office, so that we can schedule for no less than 30 minutes, but we can stretch that out to an hour and a half if we feel the patient requires it or needs a procedure. But then that volume keeps it so reasonable that we can do after hours care 24/7 essentially. Each doctor takes their own phone call, and my patient needs stitches, then I'll come in and help them get stitches. Because if I can save them the $1,500 ER visit, I've proven my value and saved them more than the cost of their family's membership for the year often. So that this is a model where you can still offer that high access level to your patients, but not feel like you're on call all the time, because you're managing the majority of things that need to be taken care of during the office hours. And you don't have the added burden of insurance paperwork and regulations and charting for simple things. And it becomes a very doable process to be available that much to your patients.
She also asks if you have patients who come in so frequently that they're taking time away from other patients.
We've never had to fire a patient for abuse of the model, and I think that's the basic question there. And I think that's in large part because we set boundaries well, where if a patient wants to come in every day because they need to, then great, that's exactly what we're here for. Every now and then you have a patient go through an emotional crisis or wound care or something, and absolutely they should come in every day. That's the fun part. But then if you have a patient who's depressed and wants to reach the cut every day, then like any good therapist, you'd set boundaries. And well, we meet once a week, scheduled time, and we're going to set our goals. You're going to work on those goals until our next appointment. If a patient doesn't like that in our membership model, they are welcome to go at any time. We don't have anything more than a 30-day contract to prevent them from leaving. That can offer so much more time than the average doctor able to offer an insurance-based system. The patients understand that they will be getting a similar service than would somewhere else. So they become very respectful of our time and of the process. But again, we're pretty good at setting those reasonable boundaries. A lot of people still consider this concierge medicine because it's insurance-free. Whether you call it that or direct care, it's good medicine. With that asterisk of the patient is usually right, they're not always right, and I want to do good medicine, not the medicine you want. And we don't prescribe antibiotics for viruses. We don't do pain medicine or benzos or Adderall for patients who don't meet criteria. And of course, we'll always keep those reasonable and limited doses and monitor refills, because you're not paying for the right to have any medicine you want. You're paying for the access to appropriate care. And texting is absolutely welcome, and email, and it's hard to abuse those things, but if a patient were, we would remind them what the boundary is so that the expectations are clear.
Josh, we're out of time, but thank you so much for sharing your experience with us.
It was great, and thank you for having me, and good luck with the rest of the conference.
Okay, thank you. Okay.